I'm going to go ahead and get started. Good morning, everyone. Welcome to Grand Rounds for May. Can't believe it's May already. I'd like to begin, as usual, with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. So now I'd like to introduce our speakers for this morning, who really do not need any introduction. I think they're well known to our Grand Rounds community, both at CHEO and beyond, but I am going to introduce them because they definitely need to be introduced. We have Dr. Jim King, who's the Chief Medical Information Officer and Professor of Pediatrics in the Division of Pediatric Medicine and Department of Pediatrics. And Karen Macaulay, who's the Chief Information Officer at CHEO. So beginning with Jim King, as I mentioned, Nutrition and Professor of Pediatrics at the University of Ottawa and Chief Medical Information Officer at CHEO and a Clinical Investigator in the Evidence Program at the CHEO-RI. Dr. King's clinical and scholarly activities are focused on healthcare system design, evidence-based care, and patient safety using information communication strategies. Karen Macaulay has a clinical background as a respiratory therapist, which led to a deep interest in using technology to support clinical care. She recently accepted the position of Chief Information Officer at CHEO and is a member of several digital health advisory councils in the region. Karen has a strong interest in using technology and data to support population health initiatives and outcome-driven care. We're very fortunate to have them both here with us at CHEO in their capacities and also here with us presenting at Grand Rounds. The title of their presentation today is Through the Looking Glass and What CHEO Found There. I love the Alice in Wonderland analogy. Our journey to HIMSS Stage 7. So with that, I'm going to hand it over to, I don't know who's going to lead off. Is it Jim?
Yeah, I'm going to start, Mona. Thanks.
Okay. Thanks, Jim.
Hi, thanks for that, Mona. And thanks everyone for joining us this morning. This is basically a continuation of the Grand Rounds that we presented in 2017. This was a start of our enterprise-wide EPIC journey. And at that time, we showed an end-to-end journey with CHEO's integrated EHR. And we're going to talk today about our journey towards specific designation with regards to the maturity of our EMR. And at the start, I'd like to say that while Karen and I are presenting this, this is an organizational-wide effort, a team effort, and that was led by a number of people, both from our IT, our operations, and our clinical side. And I'd like to give a big shout out to Jen Gillard, who coordinated a lot of the background activities and ensured that we were on track to achieve this goal. So the objectives today are just to update around our EPIC journey, to talk about how CHEO has used EPIC to help promote people, processes, and technology to improve our care, and to celebrate our HIMSS MRAM Stage 7 awards. So we received 2 awards with regards to our EMR maturity. Getting to HIMSS 7 is a big step. The Stage 7 designation from HIMSS is the pinnacle for an EMR adoption. And evidence has shown that it improves care and operating margins to around 3 to 6% with regards to your operating margin, and shows a significant increase in safety within an organization. To strengthen organizational performance and health outcomes across patient populations, HIMSS measures our clinical outcomes, patient engagement, and how we as clinicians use the technology. So I just want to step back a little bit and talk about what a medical record is. I spend, as Chief Medical Information Officer, of course, I spent a lot of time talking about this, and just relating back to our previous Grand Rounds presenter, Dr. Malkin, talking about precision health. And one of the things about getting to a place where we can do precision health is making sure we have the right backbone to allow the correct information to supply the algorithms and the data that we need to be making these decisions. Our first known medical record, and it probably wasn't really a medical record, it was probably more a medical journal, was written on papyrus back in 1600 BC and documented how to treat how to surgically treat war wounds. Hippocrates really was the first physician who documented that we should keep a medical record, and felt that the medical record should accurately reflect the course of a disease and indicate possible causes of disease. And the record up until the widespread use of diagnostic testing consisted mostly of observations. Our record was basically designed to be a memory of our patient encounters, a way that we can communicate, and more it's become a legal documentation of interactions that have occurred between the provider and the patient. Data can be organized as physician or patient-centered, and the orientations, they're not mutually exclusive, but could be time-oriented, department-oriented, or as a number of us document, problem-oriented. And the most common way to do this is in a SOAP, subjective objective assessment and plan. So we've gone from papyrus to paper to a paper hybrid, digital to, and who knows what the final outcome for our medical record will be. So basically we have paper that's been converted into a digitalized format. We have individuals accessing the records to a health information exchange where we can rapidly have access by multiple people to an instantaneous record. And our storage has gone from file carousels to servers, which then promote the ability to aggregate, to search the data, to analyze the data, and also to provide clinical decision support back to the provider in real time. Realizing that medicine's a very highly regulated, conservative, paternalistic type of environment, it's quite interesting, an analogy of how things take time to transition. Was the stethoscope, and Sir John Forbes, who wrote back in 1821 that the stethoscope will ever come into general use, notwithstanding its value. I'm extremely doubtful, because its beneficial application requires much time and gives a good deal of trouble both to the patient and the practitioner. And because its whole hue and character is foreign and opposed to all our habits and associations, I think we can see that there's some parallels perhaps to how we document into how people first felt about using a stethoscope. And then the final piece that I just want to mention is that an EMR is a digital copy of a person's medical record that often takes place within a hospital or could be within a provider's area, but it is different than an electronic health record. An electronic health record is generally a digital version of a patient's full chart and a full health record, which would include multiple different observations taken by potentially multiple different devices, and would be real-time and patient-centric. So what is HIMSS? HIMSS is the Healthcare Information and Management Systems Society. It's an independent, mission-driven, not-for-profit organization. And they have 8 stages of EMR adoption. And the model includes looking at clinical outcomes, patient engagement, and how our clinicians use the technology. It's for acute care hospitals and ambulatory care settings. They're 2 separate measures. And basically, it looks to see what your strength is in organizational performance and health outcomes across patient populations. And they're more interested in people and process than the technology, but to actually be digital, you have to have the technology, but it's actually how one uses the technology. And a lot of organizations attempt to get to stage 7, and a lot of large, very well resourced organizations, and have trouble getting there. So both CHEO and SickKids were recognized for our digital excellence in quality healthcare by receiving stage 7 designation for our inpatient and outpatient areas. Generally, meeting the requirements to do this is quite a struggle. You need to have a complete EMR. You need to have an external health information exchange. You have to have strong and robust data analytics, good governance. You have to have a very good disaster recovery plan and a privacy and security plan as well. And along with the people and the culture to pull this all together. One thing that, this is probably the nerd or geek in me. One thing that I'm very proud of with this is we have redundant backup between two sites at SickKids and at CHEO. We meet high-tech security and disaster recovery requirements, very difficult to do. You have to be over 400 kilometers apart. You have to be you can't be on a body of water. You have to have complete redundancy. And we have millisecond backup on both sites. And we do switchovers generally each year, depending on our clinical busyness, where we go back and forth. So we essentially have a hot site that's set up similar to the level of disaster recovery you would see at a financial institution, which is quite unique with regards to healthcare providers, not just in Canada, but in North America. In Canada, we're the first organizations to achieve stage 7. There's only 5 other organizations that have stage 7 for one of either inpatient or outpatient. And in the US, only about 5% of hospitals have achieved this level. This has been a long time in the making. At Epic, when you start and become a customer, they actually give you a star on their on the floor of their large auditorium. And we were the first Epic customer in Canada where we implemented their scheduling and financial services. I was actually involved in the check for background check for Epic at that time, telling you how long I've been here, and it was quite impressive. In 2010, we shifted from a best-in-breed to integrated CI, clinical information service, and we chose Epic as that provider. And part of that was we did a very deep dive into functionality, but there were a couple of differentiators that we did choose Epic. And the majority of organizations that have achieved stage 7 have actually done it with Epic information system. The first reason was that we actually knew the people who we were talking to. So when we had to reach out for service calls, you actually got somebody who knew you, who knew your kids, who you've gone out to dinner with, versus getting a call center and that wouldn't actually know your organization and what you were trying to achieve. The second part is the owner actually is quite involved in the choosing of who she allows to use the system, and had chose us. And part of that's because our husband is a pediatrician, and one of their priorities, they have 3 priorities, what they call the prime organizations that they try to sell to. And that's organizations that are academic, organizations that are pediatric, and organizations that are what they call whales, or big organizations, like the Ottawa Hospital next to us, and the UHN, which is going to go live with Epic in the next month, early in June. So we rolled out our enterprise-wide EHR. In 2017, we shared our instance with SickKids, and this has been an amazing story, and Karen will talk to you about this in just a minute, but it's been a really good win for the organization in how we've shared things and the learnings for both organizations. In 2018-19, we shared the instance with our Children's Treatment Center as they became part of CHEO, or CHEO and the Children's Treatment Center amalgamated together. We then shared the instance with Roger Nielsen House, and in 2021 started exploring our patient health provision along with our Kids Come First integrated home and community care, and the one call, one click program. Lots of work to do here, but lots of exciting promise. And I'll hand it over to Karen.
Great, thank you, Jim. So as Jim mentioned, the Kids Health Alliance initiative was a big turning point in our journey with EPIC. The goal of the KHA partnership was really about building a foundation for pediatric care in Ontario, and the way that we saw that we could start that was really working on a shared health information system, so that we could really have high quality and safe and efficient care, a more coordinated experience for patients and families across the continuum of care, and more efficiencies from an information management perspective, as well as research. So you can go to the next slide. Thanks, Jim. So the Kids Health Alliance, while it does include many different organizations, and Holland Bloor View being one, in addition to Sick Kids and CHEO. The Kids Health Alliance EPIC instance is really the Sick Kids and CHEO organizations coming together. It made sense. We do represent 60% of the pediatric services in Ontario, and I think in terms of the services that we provide, we really do complement each other. Here at CHEO, we have much more of the community based services, and Sick Kids obviously has their tertiary care and academic and research side that really helps to support our services as well. We have shared programs in terms of the cardiac program, transplant, and obviously multiple research projects that we do in collaboration with Sick Kids. So it made sense to share the data, share those patient records. We have a lot of patients that receive services at both organizations, and wanted to really start to implement some standardization for care, and doing that through the EMR. And so the vision really was to optimize care through the clinical alignment. And part of it was, wanting to be efficient with technology and wanting to be responsible from a financial perspective. But really it was about having a shared platform to have a springboard for improving pediatric care in Ontario. And of course, we wanted to meet the Ministry of Health recommendations for IT investments, where you're sharing your technology and investing together and finding efficiencies where we can. I have to say that that's continued through other technology initiatives. Every time that we go to implement any system, we first have a conversation with Sick Kids to see if they're interested in going in the same direction, and we share contracts wherever we can. So I think the partnership has really created an opportunity for us to have those discussions, and we have a shared governance between both organizations, meeting regularly to align on work plans and initiatives and priorities to make sure that we are putting resources in the right place at the right time to really deliver on our vision. So just wanted to now shift a little bit to, how we align with the CHEO strategy. And so as much as we have, that close partnership with Sick Kids, we also look internally at our strategic plan and make sure that we are implementing, features in EPIC that are going to help support our goals. And I think what we've done a good job of trying to, really look at each level of the strategic plan and make sure that we are implementing things that will help move things forward. So obviously from a safety first perspective, we have, barcode med administration, lots of infection control implementations. Every improvement made, we put towards our, improvement made goal, and always looking to optimize and grow the system. It's not a, implement and you're done. We're always looking at ways of leveraging the functionality to implement improvements across the organization. Partners in health, I would say that we have really a strong MyChart leadership team that works in collaboration with Sick Kids MyChart leadership to ensure that we are always thinking about patients and families top of mind to implement new functionality, so patients and families have quick access to the tools that they need. From a faster access perspective, we are implementing tools such as bedboard and optimizing scheduling, just to make sure that we can, as much as possible, help support the goal of faster access and getting our wait lists into a more manageable state. Wise resourcing, we have a lot of, wise resourcing, lots of work being done with lab and drug stewardship. From a staff engagement perspective, we are always keeping a close eye on, how people are feeling about their interaction and the user interface with the EMR, and making sure that it is not a barrier to the care that they provide. I think the exciting piece that we have coming up is really, now that we have a lot of data in the system and all of that data that we share with sick kids, we really can start to look at the analytics and the data to support healthier outcomes. And of course, always finding tools to make the journey for patients as well as families and providers a little bit smoother.
My apologies, I'll take my trigger finger off the mouse.
No, that's okay. So one kind of initiative that we really wanted to focus on is the role of, the EMR and Epic as we went into the pandemic. And I think this really shows that when you make an investment in technology and set up a good foundation, that you can pivot quickly and implement a lot of functionality that will help support care in a short amount of time. And one of those areas was around virtual care. So really, we had done some virtual care pilots, especially working with the endocrinology department prior to the pandemic to implement some Epic Zoom integrated virtual visits. And we were able to take that work and quickly roll it out to the rest of the organization when we pivoted to needing to increase our number of virtual care visits. But we didn't stop there. We went on to, really look at how we could leverage those tools for family and patient rounds, as well as virtual ED visits. And the beauty of having it all in one system and having access to discrete data is really that we can then pull the metrics and really have a good understanding of what's happening throughout the organization. So we do have a virtual care dashboard that we implemented that helps us to see how many clinics are providing virtual care, the number and volume of visits. And of course, this fluctuated throughout the pandemic as we went from one wave to the next. But we were able to see where those visits were happening, where the high volume, what clinics were doing high volume of virtual care. And then we were able to connect with those clinics to make sure that they had the tools and the workflows that they needed to support that care. And really, when you look at the amount of synchronous and asynchronous encounters that occurred, really 73% of our patient encounters were happening virtually. And in terms of MyChart two-way messaging, we do see over 2,000 messages between providers, patients, and families every week. And that's something that, we were trickling along to try to get people live with that two-way messaging, but the pandemic really helped to ignite, the drive to get that up and running for many of the departments. And I think many are seeing it as a way to connect with patients and families in a quicker way. And we could also keep track of our service delivery during the pandemic because we had that data. And I have to say, talking to other organizations, this is one area where they struggled. They didn't have the data to know how they were doing in terms of providing the services that they needed to as they ramped up and ramped down, and to see where there might be concerns about areas that may have been impacted in terms of the number of visits. So we were definitely able to report on our number of virtual ED and inpatient rounding, medical outpatient appointments. And then as we did our surgical ramp up or ramp down, we were able to look quickly to see our metrics in terms of our wait list and the number of patients that we were seeing. We were also able to pull data on the COVID-19 Assessment Center in terms of how much testing we were doing, as well as pediatric patient assessments and supporting ED as well. So just a little bit about the COVID Assessment Center. I know that it's familiar to everybody, but it was a way that we could quickly set up an assessment site in partnership with TOH. We did move quickly to open scheduling, which is something that we didn't have in other areas of the hospital. But because we had access to the functionality in Epic, we were able to stand that up fairly quickly. Obviously bumps in the road, but at least we had access to the functionality that we could roll out to the community to be able to book those community assessment appointments. We were able to streamline documentation to allow for really a high volume clinic to be able to see as many patients as possible by decreasing the amount of work that clinicians had to do in Epic. And we implemented immediate release of results, which, as you know, many of our results have the 5-day delay, but for COVID results, updated those rules in order to get the information to the patients and families quicker. And we're rolling out more instant activation of MyChart. And so this was an area that we trained the clerks to be able to get people live on MyChart as quickly as possible, not only to be able to see those results, but also if they were a CHEO patient to be able to have that kind of two-way messaging with the providers to help with some of the virtual care needs. So now we just wanted to talk a little bit about the compliance data that we were responsible for submitting as part of our HIMSS evaluation. HIMSS really wants to see that you're leveraging the tools as much as possible. And as Jim mentioned, it's not about the technology that you're using. They are vendor agnostic. It's really about, are you using the patient safety tools and the functionality that is really meant to support clinical care. So one of the metrics that they ask is that we confirm that we are submitting orders electronically. So both in the inpatient and outpatient areas that you're, excuse me, then you are able to leverage all of the clinical decision support tools because you are placing those orders electronically and getting the prompts that you need to from a patient safety perspective. And then, as I mentioned before, the barcode scanning of medication administration is a key safety feature, and they want to make sure that you are compliant. So I have to give a big shout out to our nursing staff and nurse educators who really took it upon themselves to dig into the workflows related to barcode scanning and to see where we had improvements that needed to be implemented, both from a workflow and technology perspective and just an awareness and training. So we were able to successfully meet the compliance rates, and we continue to have high compliance rates, and we will continue to monitor that at our medication safety committee. And just quickly a little bit about, you know, I guess what some people call the candy of having an EMR, and it's really around being able to have data. And so we do have a BI strategy here at CHEO that we are implementing. And obviously the first few steps was just getting a system in that we could actually collect the data. But we are moving into a period of time where we have access to a lot of data. And now we are pulling together many reports and dashboards so that clinicians have the information that they need to be able to you know, inform their care. And so we are putting together a bit of a strategy or a roadmap in terms of how we will implement all of those reports and dashboards, and really just wanting to be able to, you know, measure as much as we can. It's more than the technology. It's not just about gathering the data and having access to it, but it's really how are we going to use that data to really drive change. And so one area that we leveraged this was with the operations center, or it was initially called the command center. So many of you would remember back in the fall of 2019, there was a desire to really have improvements implemented to help with patient flow within the organization. And the fact that we had data in Epic, we were able to quickly stand up a command center where we had real-time data that would help inform where there were barriers to flow. And our patient, our clinical operations managers use this day to day, where we kind of look at that the dashboard and really start to see where the barriers are and where we can remove those barriers. I have to say that having a group come together and look at the data, validate the data, understand it was so helpful. We were able to make changes quickly, so that really what people were seeing in terms of the metrics was reflective of what they were actually seeing in the clinical areas. Of course, we had to move to a virtual command center in 2020, but thankfully we did have this operations center dashboard where no matter where you are, you can access it through Epic, and it really gives you kind of situational awareness of what's happening in the organization, where there are barriers and really the status of some of those patient flow items. And we went a step further, not to just make it about one group of people having access to that data, but we did roll out the Epic monitors across the organization so that data and that information could be available to all of the units, so that they understand what their colleagues are going through throughout the hospital and where they can maybe help, or where maybe they could ask for help. And all of the data really does inform on a day-to-day basis our patient safety tools. So we have an 8:15 check-in every morning for a group of our on-call leaders, and we use the dashboard to inform what the day is looking like and where we might need to shift our resources. That informs our report out that goes to the daily brief, and then the information is also used at daily bed meetings, and we also have it in the exec hallway. Again, it's a way of really getting a sense of where we're at from a clinical perspective on a daily basis.
If you look at the operations report from February 15th, 2022, you can see that Karen and I stay closely involved in the process with the clinical operations situation report and attending the meetings. So it gives us a good idea of how the functionality is being used, and if there are any other things or improvements that need to be brought forward. So I'm just going to take a couple of minutes to walk through some case studies, and there are a number of physicians, some of them who are on the attending rounds that were quite instrumental in providing background information to this, and we are very thankful for their participation, and also their involvement when the HIMSS site visitors virtually came on site and walked through our different clinics. The first is Claudia Malik. Claudia is one of our pediatric plastic surgeons and is a physician champion builder. Claudia is also the vice chair in quality and patient safety for the Department of Surgery at the university, and has been doing just a phenomenal job with regards to quality improvement in surgery, and has done a lot of work on surgical site infections and discharge instructions. This was a multidisciplinary project that looked at the Pediatric National Surgical Quality Improvement Program and also solutions for patient safety bundle for surgical site infections. I'm gonna run through this fairly quickly, but basically we had a surgical site infection rate of about 2.8%, and the target should be less than about 2%. You're always going to, I shouldn't say always, I know Dr. Tampi is on the call here, but you will often have surgical site infections that you can't control. Some surgeries are dirty anyway. It's just the nature of the risk in that, but you do try and decrease the actual rate to as low as that you can, and targets have been set for less than 2%. On the SSI bundle, that's required for high-risk surgeries like shunts, cardiac, and spine surgeries, but Dr. Malik implemented this across all surgical cases. And I just, on the far right-hand side, I just highlighted where Epic-based reports were being used to help pull out the data. And This was all built into an EPIC order set and a NISQIP work list build. Also used discharge instruction standardization. There were those specific audit tools and then ongoing PDSA cycles to highlight and improve this. And quite nicely, the surgical site infections decreased to less than the target of 2%. There was a little bit of a COVID-19 pandemic blip there. Not sure exactly why that was, but overall the trend has been down, which is quite good. Then in the other part with the post-op discharge instructions, these discharge instructions increased from about 80% to 100% of patients going home with discharge instructions. There was a significant increase noted by families with the quality of information that was provided. And then Dr. Bertoli has done some look at their uncomplicated appendectomies and has shown a significant decrease in hospital and ED return visits. And on average, I just calculated that there could be about less than 30 ED visits per year following uncomplicated appendectomies for things like questions around the wound and care around the surgery itself. So great accomplishment that led by Dr. Malik regarding quality improvement in the surgical area. The other thing I'd like to highlight is work that Emily Smith and Sinthu Sundarlingham did. Sinthu has unfortunately moved on to greener pastures, but has done just get another yeoman job with regards to physician builder champion, and just did a number of very amazing quality improvements in the mental health area. But in 2014, we had a critical incident review and a board mandate to improve our suicide screening for admitted patients. Sinthu, Emily, Dr. Pager, there was a large team together and pulled out a screening tool to embed within the EMR. This is the head to toe screening assessment. And basically, this has become an Accreditation Canada leading practice. You can go on the site and look at the recommendations for how to do this. This is quite nicely done. There was a phenomenal education campaign around this, and then the ASQ tool, the screening tool for suicidality, which is a 5-question tool, was embedded within the daily care and safety workflow. Safety flow sheet that nurses use to ask any patient coming into the hospital over age 12 that whether they had specific risk for suicide, and depending on how they answered, that would lead to recommendations, and then reporting compliance back to the unit managers to be able to see how we were doing. And this is quite a nice story. So basically, we're showing a overall improvement with time of how many patients are completing the tool. But what was quite shocking, I guess, to some extent, is that 16% of our eligible, we were screening 91% of our eligible youth, and 16% were screening positive. This is quite a high rate. These are patients that would have otherwise gone undetected, and all positive patients with a positive score received mental health assessment and support services. So that the literature suggests a slightly lower number. However, there is data that's been released, and this again is led by EPIC Research. There's something called Cosmos, where EPIC pulls together large groups, and Judy Faulkner, who's the lead, the owner of EPIC, meets on a bi-monthly basis with Alex Hunter, and Alex highlighted to Judy the fact that we were seeing a higher number of youth that were expressing suicidality, and EPIC went and ran its numbers through its Cosmos and actually have confirmed this across multiple sites, that there has been an increase in suicide ideation amongst youth during the pandemic. And then the other piece that I wanted to mention, and this is Dr. Radhakrishnan's work around CHEO Asthma program, which was launched in 2018 and received funding through the foundation. Dana has been using evidence and EHR tools to improve asthma education and information. So asthma is extremely common chronic disease, perhaps the most common chronic disease in children. It's a leading cause of ED visits and admits, and there's really good evidence that if you can do good education, you can reduce asthmatic children's ED visits and admissions. So basically, an asthma action plan, which is available through integrated into Epic and available on an ABS and MyChart. And then has been leading an asthma education program and developed a BPA for emergency physicians to increase referrals for patients who qualify for asthma education. As of when I checked, when we did the presentation earlier in the year, the BPA was launched 443 times and resulted in 61 asthma education orders. So that's 61 extra patients that were referred for asthma education that may have been missed otherwise. And overall, the BPA has led to an increase in asthma education orders. And among patients who have post-initiation of the asthma education program, there's been a significant reduction in the number of repeat hospitalizations and a decrease in the number of repeat ED visits. So again, quite great work. And it's one of the things that this isn't actually a very costly initiative and may actually save the system quite significant dollars. The final program I want to mention quickly is our One Call, One Click program, and this is a program to get our patients with mental health and addiction and with needing mental health and addiction care to the right provider at the right time and as quickly as possible. And basically, it's one number to call or a link to click, access to virtual service and service matching, hands-on coordination, and peer and family support. It's an exceptional program. And in the background, we have been standing up the program through Epic with using EC Link initially. And one really exciting thing is we've just done an integration into the Ocean e-referral platform. So this is providing great support of bringing referrals in electronically through the Ocean e-referral system, but we are looking for a bi-directional e-referral platform through Ocean that we're hoping will allow electronic incoming and outgoing referrals to be managed within our system. So no paper anymore, no need to write on a napkin for a referral and then try and decipher the handwriting. This would all be done electronically and using a platform that a large number of our community providers are already using and integrates within their EMR. Just a quick mention around decision support. There's a lot of medication alerting built in the background. We have dosing rules, alerts, and all of this was built with a lot of thought using Epic Alert recommendations, our P&T committee, and Stanford Children's Hospital's background rules. So we were able to get access to them and bring them into our system. And these rules were then incorporated by sick kids. So we know that they're strong and robust. We have dosing, allergy, drug interaction, critical lab alerting, and these are we're providing this as evidence-based content at the point of care. So, for instance, if you try and order warfarin, you would get the latest hemoglobin, the INR, and platelet count for the patients, and when it was last done to help you make a decision about ordering that medication. We have specific best practice advisories put in that run in the background. So if a baby meets the criteria for receiving RSV prophylaxis, that there is a background alert sent to the RSV clinic that will trigger the nurse to contact the family. And this alert was put in place because a number of years ago we missed a baby who was eligible for prophylaxis who then got admitted with RSV. So this is quite nice to be able to capture the babies we may miss in the background. There's a lot of COVID-19 alerting that's been placed for infection alerts, ED triage, screening fails, suggested COVID-19 testing, and if there's an isolation infection mismatch, there's an alert as well. And then we also ED travel screen for high-risk pathogens, Ebola, MERS, COVID, and avian flu. And then one piece that I'm really proud of is our ED Sepsis Alert. So this was built with our Sick Kids partners. Sick Kids had this alert in place. They did the big dig around this. So they actually did the validation work that looking at making sure that this was working in the background before they turned it on. And basically the alert runs off of our CTAS, the Canadian Triage and Acuity Scale. And then if there's a sepsis risk assessment, the alert is fired, which leads to a huddle. And then a decision is made whether or not the patient meets sepsis criteria or not, or meets watch criteria. Since inception, this is fired 560 times. We've not gone back yet to look at the number of positives or how we've actually caught a patient with sepsis. If you believe that there is sepsis, you can click code sepsis, which then leads to the sepsis sepsis order set. And then there's continued evaluation if the patient remains unwell. So if you don't think that the patient was septic, but the patient stays tachycardic and febrile, then the BPA will refire. And then also if treatment has not been started in the correct amount of time, which is 60 minutes, then the alert will fire again as a reminder. Just quickly with regards to patient portal usage, this is our MyChart. There's many features that are live today, including the family's availability to review future and past visit information, to view health information, their test results, allergies, medications, letters and notes that are sent at the provider's choice, and growth charts. You can review health updates and for meds and allergies that the family can place. There's a mobile app. There's automated references to education resources. We have secure two-way messaging, including photo and video attachments that can be added to the chart. We've been developing patient questionnaires. We have video visits set up through MyChart and open scheduling that's being enabled, and more to come on open scheduling as we get into our next release. MyChart's been incredibly successful, driven somewhat by the COVID-19 Assessment Center, but currently we have close to 90,000 patients live. Almost over 40% of our active patients at CHEO are live. We are one of the highest uses of MyChart across all Epic sites across North America, and we are exchanging greater than 7,000 messages per month. And you have to think that these were messages that in the past required phone calls and telephone tag. And now these messages are much more efficiently dealt with. Patients and families, this is work that Ellen Goldblum has led, tell us that MyChart helps them understand their condition and the care they're receiving. It helps provide better patient care to them. And it also helps them avoid calling their clinic. So again, improves efficiency with regards to, and this is stopping a call to the clinic. I'll pass it back to Karen quickly for our health information exchange.
Yeah, thanks, Jim. And I will go through these quickly so we have time for questions. But, you know, similar to virtual care, the pandemic really has moved forward health information exchange, interoperability, and data sharing. We've done more in the last 2 years than we've really been able to move forward in the last 10. So it is an exciting time. This slide just really highlights where we're sending our information to outside of Epic and to many different databases. During the pandemic, we quickly stood up Care Everywhere, which is a functionality within Epic to be able to share information with other organizations. We did set this up so that we could quickly have information shared with mostly the Ottawa Hospital for our needs, but also with other organizations. And I'm excited to say that we are now working towards sharing information with non-EPIC hospitals. So there is an initiative that will go live at the end of the month where TOH will be sharing information from a point-to-point perspective with Queensway Carleton. And then we will move forward with Sick Kids and CHEO sharing information with Holland Bloorview to be able to have that two-way communication. So we do have a dashboard in Epic, which helps us to see how we are exchanging data in terms of the number of records sent and the number of unique patient and records we are exchanging. And you'll see there that in terms of our trading partners, it's really those Atlas Alliance sites that have the highest volume. I think this is an older screenshot, and I think we're above 1 million records now that have been shared. And so in terms, just on the next slide is just really, this is a report that Epic generates just in terms of how we're exchanging records within Canada. And at this point, CHEO is really accounting for 80% of those record exchanges. That will change a little bit as UHN and Hamilton Health Sciences goes live. But you can see there that really it's the trading between ourselves and the Ottawa Hospital that is really contributing to that large number of records being exchanged. So a lot going on in this space in terms of interoperability, lots of exciting initiatives, and certainly, working with other organizations to see how we can standardize across the province so that people are not kind of working on their own initiatives and not having systems talk to each other. So lots of good work going on there.
Just quickly, the feedback from the HIMSS evaluators felt that we had lots to be proud of. They recognized our use of analytics and daily decision-making, our governance, and they noted that and I was quite pleased with this, we're one of the few organizations that have effectively removed technology barriers to try and decrease the impact in clinical workflows. They thought there were some opportunities for us to focus on clinical outcomes, how we can use our functionality and data to measure and track the outcomes. And there's a couple of new things that will be coming up in the future about scanning of formulas, and also felt that we could work on some of the automatic alerting to prompt changing of lines, drains, and airways. My add to that is, I think we've done a phenomenal job getting an infrastructure in and set up, and that's been recognized externally. But we have work to do on our analytics to blend our operational quality and research information collection and use. We need to move more from our tacit data collection to discrete data capture. That's a big lift, but I think we need to be very thoughtful. We're at the point where I think we can do that. And we need to finish our business systems planning and implementation, which is underway right now, and start moving all of our administrative, operational, and clinical data into a data warehouse so we can really know exactly what the impacts are that we're having amongst our patients, and then link that back to our outcomes. There's great opportunity to grow our population health focus with our Kids Come First programming and our one call, one click. There's multiple areas that we can look at how we can improve this. We need to continue to work on the support for our staff and physician engagement. It's been phenomenal. And I think we need to make sure that we continue to be thoughtful in how we do that. And then finally, for me, this is one of the things that I really, when we started this 10, 15 years ago, is how do we get evidence-based decision support right at the point of care? And now that Hamilton Health Sciences is going live and the McMaster sites will be live, McMaster is offering an embedded access to the McMaster Access Smart Search evidence-based search program. So we are undertaking the integration for that, and I'm hoping to come back and speak to people in the future about how they can actually use the McMaster Access and get real evidence-based information at their fingertips as they're seeing their patients. So I'll end there and ask if there's any questions for Karen or I.
Hey, thank you very much, Jim and Karen, for an amazing presentation. You summarized years of work, many hours per day of labor amongst many people to get to what you presented today. It really is phenomenal, and it's hard to imagine life without Epic here. And I say that in a good way. It really has changed how we're able to deliver care from everyone's perspective. We have time for maybe 1 or 2 brief questions. If anybody has a question, you can go ahead and raise your hand or unmute yourself and start to talk. One thing I wondered about as we talked about this, so, I was thinking about future opportunities, but even before we get to future opportunities, one thing that strikes me is, Epic, as we currently have it, has so much functionality, and I wonder how much of that functionality most of us are actually making use of. And I wonder if you have any comments about that and what we can do about that.
Yeah, we've for sure. It's a very deep program, and there are multiple pieces. We are looking at how we bring forward an educational program. The Epic website itself, which we're all allowed to access, has multiple videos about how to do that, just very quick, poignant points. And then we're looking at how we can sort of bring those forward to allow people to get access to see it. Part of the challenges of the variability in how people provide care. So there's sort of how do we support people in doing the job they're doing and to be more efficient around it. And then how do we also use the functionality in the background to sort of take away some of the annoying things to allow better use of the time that you have within the system.
Great, thanks. There's 2 questions. If they're brief, we can do both of them. We'll go first with Tom Kavesi and then Uday Chadha. Go ahead, Tom.
Hi, so just briefly, just want to congratulate Karen and Jim for their incredible work on this. I think, especially with COVID, this all saved our bacon. I did want to correct one error Jim made on his first slide. The picture of what he was calling Egyptian hieroglyphics, that was actually a shortcut which Jim took. That was actually a scan of one of my consults done in the paper chart. Before
I didn't want to say that, Tom.
I recognize the patient.
Thanks, Tom. Go ahead, Uday.
Hey, Jim, nice to see you. Excellent presentation. I was wondering how a community pediatrician, now that that's what I am, can interact, because having the phobia of IT, I haven't progressed as well as you have. I'm still stuck in the 90s and 2000s of IT. So as a community pediatrician, what role we can play and how can we benefit?
Yeah, that's a great question, Uday. How do you sort of level the playing field, I guess, to a certain extent across a system that allows a lot of variability in it? And even the variability amongst the systems that are available in the community through Ontario MD. And a lot of people, there's a lot of political and different decisions behind this, but people may not know that when Ontario MD rolled out its EMR program, it was primarily developed for family physicians, and pediatricians weren't included within that program. So there was no incentive, financial or support to actually onboard at that time. So in some ways it left pediatricians hanging to a certain extent. A lot of people have bitten the bullet and have their own community-based EMRs, but we are looking to how we can connect those EMRs together. And one thing that we do is we allow access through Epic Care Link, so that if you have a patient who's being seen at CHEO, you can access the system, and you can get, and there's training materials to help you with this, access to all of the fulsome information for your patient that's seen at CHEO. If you do have an EMR, we send all of our information to the community-based repository, data repository, and that can be downloaded into your EMR. And then the integration with Ocean is going to allow us to have better communication back and forth with regards to receiving referrals and then providing information back about where that referral is on the list and what's happening as we walk through the referral.
Thank you.
Thank you for the question, and thanks, Jim, for the response. We are out of time. There is another question in the chat. I'm just going to ask maybe if Jim and Karen can respond to the question offline. It looks like there may be a lot to that question, so I'll leave that to you to follow up on. Thank you again very much for the great presentation and the discussion. Really, really important for us and so valuable.
Our pleasure.
Thanks so much. Thanks for the opportunity.
Bye-bye.